At 4:12 in the morning, the monitor said my patient should already be dead, but she was still breathing. My name is Dr. Lauren McBride. I'm 47 years old, and I've been working emergency rooms for more than 2 decades. I don't scare easily. I don't believe in ghost curses or hospital legends. I believe in labs, scans, and numbers that can be verified. If a machine says something, there's a reason for it. That's how medicine works. That's what I thought. It was a cold Thursday night at Easton Ridge Medical Center in Pittsburgh. Around 11:38 p.m., EMS rolled in a 34-year-old female trauma patient. Her name was Rachel Monroe. She had fallen from the upper ramp of a downtown parking garage, head first onto concrete. No helmet, no protective anything, just bad luck and gravity. Her Glasgow coma scale was 4 when she arrived. That's barely responsive. We intubated her immediately. Blood pressure unstable but not crashing. Pupils unequal. CT scan showed bilateral subdural hematomas and midline shift, the kind of scan that makes the room go quiet. I called neurosurgery. Dr. Ethan Klein was on call. He'd been doing this longer than I had. He took one look at the images and said, "We're going upstairs, now." By 12:25 a.m., she was in the operating room for a decompressive craniectomy. They removed sections of skull to give the swollen brain room to expand. Standard procedure in severe traumatic brain injury. An intracranial pressure monitor was placed before closing. Everything about it was textbook. The surgery ended just after 3 a.m. Ethan told me it went as well as it could have gone. They evacuated the blood. No new bleeding. Brain tissue bruised but not catastrophic. The ICP at closure was 21. Elevated but manageable with sedation and medication. At 4 a.m., Rachel was transferred to Neuro ICU unit, 7-room 712. I should have gone back to the ER and focused on the next crisis. That's usually how it works. But I've learned something over the years. When a case sticks with you, pay attention. At 5:52 a.m., my phone buzzed. It was Tessa Wilkins, the Neuro ICU charge nurse. Lauren, her ICP, just jumped to 44. That's high. Not unheard of. But high. Did you zero the line I asked? Yes. Waveform clean. Yes, I'm coming up. By the time I reached room 712, the monitor read 51. Rachel was sedated, ventilated, and hemodynamically stable. Blood pressure controlled. Oxygenation fine. Pupils sluggish but reactive. 57. Any change in exam, I asked. No, Tessa said. Nothing that matches that number. We pushed hypertonic saline, increased sedation, adjusted ventilation, standard protocol. 63. Now we were in dangerous territory. If that number's real, Ethan said quietly, she should be herniating. But she wasn't. We ordered a stat CT. No new bleeding. No dramatic swelling beyond what we expected post-op. No structural reason for ICP in the 60s. Back in ICU. I watched the monitor climb to 68. I've seen equipment malfunction. I've seen bad lines, bad calibration, human error. So we replaced the transducer. No change. We replaced the entire monitor system with a different unit from a different manufacturer. The number held at 70. Caleb Rourke from biomedical engineering showed up half awake but fully skeptical. He checked the cable integrity power supply grounding. He recalibrated everything from scratch. Waveform looks physiologic, he said. It's not noise. 72. Rachel's heart rate was steady. Blood pressure acceptable. Oxygen saturation perfect. None of it matched. And that's the part that still gets me. Because medicine is built on patterns. When pressure inside the skull rises that high, the body reacts in predictable ways. Cushing's triad, bradycardia, hypertension, irregular respirations. We weren't seeing the full picture. Around 2:40 p.m., the ICU team performed a brief sedation pause to reassess her neurological status. It's a controlled interruption just long enough to evaluate response. I stood near the bed while Tessa adjusted the infusion. Rachel's eyelids fluttered. Then they opened. She tracked movement, slowly but clearly. Is she localizing? Ethan asked. Yes, I said. She is. The monitor read 74. If you work in a hospital long enough, you learn that numbers matter. But the human body matters more. When the two don't agree, something is wrong. This is the part where most people would assume equipment error. That's what I told myself. That's what I wanted it to be. Because if the machine wasn't wrong, then everything I understood about severe brain injury needed to be re-examined. Before I go any further, let me ask you something. If you've ever worked in a hospital or experienced something in medicine that didn't make sense at first, leave a comment below. I read them. And if you want more real doctors and nurses' stories that don't rely on ghosts to be disturbing, subscribe to the channel. What happened next is still something I think about during night shifts. By late afternoon, Rachel was back under sedation. ICP fluctuated between 70 and 76. We double-checked labs. Electrolytes normal. Blood gases stable. No metabolic explanation. I rested my hand lightly against the blanket over her chest while reviewing the chart, and that's when I felt it. A faint vibration. Not her heartbeat, not the ventilator cycle. Something slower, subtle, almost like the hum of a distant engine. I lifted my hand. Nothing. I placed it back. There it was again. I didn't say anything at first. In a hospital, if you announce something strange without proof, people assume you're exhausted. I adjusted my position and tried again. The vibration was still there. Tessa noticed my expression. What? Put your hand here, I said. She did. Her eyebrows tightened slightly. You feel that I asked? She didn't answer immediately. Maybe it's the bed motor, she said finally. Maybe it was. That would have been simple. Caleb checked the bed frame, turned the motor on and off, disconnected it entirely. The vibration didn't change. The monitor climbed to 78. I told myself it was mechanical resonance. Building vibration. HVAC system. Pittsburgh has enough bridges and heavy industry to rattle anything. But when I stepped back from the bed, the sensation stopped. When I stepped closer, it returned. 79. I've trusted monitors my entire career. They've saved lives. They've warned me before things became obvious. That afternoon, I found myself staring at a number I couldn't reconcile with the human being in front of me. And for the first time in 22 years of emergency medicine, I wasn't sure which one I should believe. I kept my hand on this blanket a few seconds longer just to be sure I wasn't imagining it. The vibration didn't disappear. It wasn't dramatic. It wasn't shaking the bed or rattling equipment. It was subtle, almost polite. The kind of thing you could dismiss if you wanted to. I stepped back again. Nothing. I stepped forward. There it was. "Caleb," I said. Keeping my voice neutral, check the floor under this bed. He crouched down, pressed his palm against the tile, then the metal frame. "I don't feel anything unusual." Tessa leaned in again and placed her hand where mine had been. "It's faint," she said. "But yeah, it's there." The monitor ticked up to 80. Rachel's blood pressure was 132/78. Heart rate 76. Oxygen saturation 99% on the ventilator. Nothing about her systemic vitals suggested imminent herniation. I glanced at the waveform on the ICP screen. It looked clean. Crisp peaks. Normal morphology. Not artifact. Not random spikes. "If this is real," Ethan said quietly, "we're missing something." We reviewed the CT scan again on the workstation in the corner of the ICU. No expanding hematoma. No new bleed. Edema was present but consistent with post-operative swelling. No midline shift progression. Could it be compartmental pressure, I asked? Localized elevation not obvious on imaging. Possible, Ethan said. But at 80, we'd see more. Caleb stood up and brushed dust off his scrubs. I checked the grounding. Electrical is clean. No fluctuation in supply. If there's vibration, it's not coming from the bed motor. HVAC, I asked. I'll call facilities. The number held at 81. I've worked long enough to know that when something doesn't fit, your instinct is to simplify it. Machines fail more often than brains defy physics. Let's pull the catheter, Ethan said. Place a new one. That wasn't a small decision. It meant taking her back to procedure, reopening a sterile field, introducing fresh risk. Do it, I said. Within the hour, a new ICP catheter was placed under sterile conditions. Proper depth, confirmed position, fresh calibration. The screen flickered as the system booted. 78. It didn't budge. 82. Tessa looked at me. That doesn't make sense. No, I said. It doesn't. We ran labs again. Sodium slightly elevated from hypertonic saline, but within therapeutic range. Carbon dioxide levels controlled. No hypoxia, no fever. I pressed my fingers gently along Rachel's neck and jawline, checking muscle tone. Nothing unusual. No rigidity beyond what sedation would cause. Sedation level, I asked. Propofol at target? Fentanyl steady? Tessa said. Let's increase sedation slightly, Ethan suggested. See if it changes the number. We did. The ICP dipped briefly to 76, then crept back up to 83. Rachel remained hemodynamically stable. The ICU around us moved on as I see us do. Alarms from other rooms. Nurses adjusting drips. Respiratory therapy checking vents. Life and death playing out behind curtains. Inside room 712, we were staring at a number that refused to behave. Facilities arrived and inspected the ventilation ducts above the ceiling panels. No abnormal mechanical vibration. No loose components. No industrial equipment cycling at that frequency. Caleb brought in a handheld vibration meter from biomedical storage. He placed it on the mattress, then on the bed rail. It's picking up something, he said. Low frequency, not high amplitude. From where? I asked. He moved the device to the floor beside the bed. The reading dropped. Back on the mattress. It rose again. Could be structural resonance, he said. Hard to say without more data. The monitor read 85. If her ICP is truly 85, Ethan said she should be declining fast. But she wasn't. Her pupils were still reactive. Slightly asymmetric, but reactive. We checked again. Still reactive. I've pronounced brain death before. I know what catastrophic neurological collapse looks like. This wasn't it. Another CT, Tessa asked. We just did one, Ethan said. Radiation isn't the issue, but it's not going to show us something new in 2 hours. I leaned against the counter and watched Rachel's chest rise and fall under mechanical ventilation. I've always believed that machines help us see what we can't. That's the point of monitors. They extend our senses. But what happens when your senses and the machine disagree? Caleb adjusted the vibration meter again. Frequencies around 18 hertz, he said. Low, subaudible. Is that dangerous? Tessa asked. Not typically at this level, he replied. People are exposed to low-frequency vibration all the time. Buildings, traffic, industrial systems. Is it enough to interfere with the catheter? I asked. He hesitated. In theory, if the transducer is sensitive enough, maybe, but the waveform looks physiologic. That's the problem. 87. I felt the room tighten. Ethan rubbed his forehead. Let's reassess everything from the beginning. Trauma mechanism, intraoperative course, post-op meds. Maybe we're anchoring to the number too much. Maybe we were. I stepped back to the bedside and looked at Rachel without looking at the monitor. She looked like every other severe TBI patient I've treated. Sedated, ventilated, fighting a battle her body might or might not win. I placed my hand on the blanket again. The vibration was still there. Faint, persistent. Caleb, I said quietly. Can you record that frequency over time? I can try, he said. But this isn't exactly a research lab. Just log what you can. He nodded. The ICU lights dimmed slightly as evening approached. Shift change was coming soon. I watched the staff move in and out of the room, each of them glancing at the monitor, each of them trying not to react. The number held steady at 88. No spike, no crash, just sustained, impossible pressure. Rachel's blood pressure remained within target range. Heart rhythm regular. Tessa looked at me. Do we call this refractory intracranial hypertension? That's what the chart will say, I answered, because that's what the data showed. But as I stood there feeling something that didn't belong, I realized the problem wasn't that we lacked information. It was that we had information that didn't fit inside anything we'd been taught. I moved my hand slightly lower on the blanket closer to her sternum just to see if the sensation changed. It didn't. The vibration was steady low, almost like a distant engine idling somewhere under the floor. Not strong enough to move the bed, not loud enough to hear clearly, just there. I glanced at the monitor again. 89. Rachel's face was relaxed under sedation. No grimacing, no posturing, no sudden neurological shift that matched that number. Tessa, I said quietly, come here again. She stepped to my side and placed her palm where mine had been. She didn't speak for a few seconds. It's not the vent, she said finally. That rhythm's different. The ventilator cycled predictably. Inhale, pause, exhale, mechanical and precise. What we felt was slower. Caleb returned with a small data logger attached to the vibration meter. He set it carefully on the mattress beside Rachel's shoulder. "Let's see if this tracks consistently," he said. "If it does, we can analyze the frequency pattern." "Could this affect the ICP reading?" I asked. He hesitated. "If the transducer is sensitive to micro-movements, maybe, but the waveform still looks like actual intracranial pulsations. It's synchronized with cardiac rhythm. That's what's throwing me off." I stared at the screen. The waveform peaks aligned with her heartbeats. That part made sense. The baseline, however, was sitting far higher than it should. 90. Ethan stepped back into the room after reviewing additional imaging. "There's no structural explanation," he said. "At least none we can see." "We replaced the catheter," I said. "I know." Rachel's blood pressure began creeping upward, 148/90. Not catastrophic, but trending. "Let's adjust sedation again," Ethan said. Propofol was increased slightly. Fentanyl steady. Mannitol had already been administered earlier. The number dipped to 86, then climbed back to 91. I exhaled slowly. I've always believed in pattern recognition. You gather enough data, something becomes clear. But here the data refused to cooperate. Lauren Tessa said, "Feel this." She guided my hand to the side rail of the bed. The vibration was faint there too, but weaker. "Now step back," she said. I did. "Nothing." She stepped back. "Nothing." We leaned in again. It returned. "Localized," Caleb muttered. He moved the vibration sensor to the floor beside the bed. The reading dropped significantly. Back on the mattress. It rose. "Frequency stable around 17 to 19 hertz, he said. "Low frequency. Subaudible range." "Could traffic outside cause that?" I asked. "Maybe. But it wouldn't be isolated to just this bed." I looked around the ICU. Other rooms were full. Other monitors humming. No one else reporting anything unusual. "Check the room next door," I said. Caleb walked into 714 with the meter. A few moments later he returned. "Normal baseline," he said. "Nothing significant." The monitor in Rachel's room read 92. I felt the weight of that number settle in my chest. If this pressure is real, Ethan said she's living on borrowed time. But her exam still didn't reflect catastrophic deterioration. Her pupils were checked again. Reactive, not fixed, not blown. I've seen fixed pupils. There's a stillness to them that you never forget. Rachel's eyes, when briefly assessed during sedation adjustment, didn't show that. "This is either the strangest case of refractory ICP I've seen," Ethan said, "or something else is interfering with our measurement." "Define something else," Tessa said. "Environmental artifact. Mechanical influence. Something we haven't identified." The ICU doors opened and closed as staff moved through shift change. The evening team came in. Reports were given. Rachel's case took longer than most. ICP 92 stable vitals, minimal neuro change, Tessa summarized carefully. The new nurse raised an eyebrow. 92? "That's what it says," I replied. He stepped closer to the bed and placed his hand lightly on the blanket without prompting. After a moment, he looked at me. You feel that too? Yes, I said. That acknowledgement did something subtle in the room. It wasn't hysteria. It wasn't panic. It was recognition. Caleb adjusted the data logger again. The amplitude's low, he said. It's not enough to physically shake the catheter. But it's persistent. Persistent how? I asked. It's not random. It's steady. The monitor flickered briefly as the system recalibrated. 94. Rachel's heart rate remained in the 70s. Oxygenation perfect. I stepped to the foot of the bed and folded my arms, watching her. I've worked in trauma long enough to know that sometimes you're simply buying time. The brain can swell unpredictably. Secondary injury can evolve. But usually when it does, the body shows you. This body wasn't following the script. Let's document everything precisely, I said. Every change, every intervention, every reading. Tessa nodded. Already charting. Ethan checked her pupils again. Still reactive. He shook his head slightly, not in disbelief but in concentration. Could there be compartmental pressure not visible on CT? He said. Deep structures. Possible, I answered. But at this level, we'd expect more systemic response. The vibration under my palm continued. Not stronger, not weaker, just constant. Caleb leaned closer to the monitor. Waveforms consistent, he said. No sign of line obstruction. No damping. So the catheter believes this is real, I said. Yes. 95. The room grew quieter without anyone saying so. Not silent. ICU is never silent. But the conversations around us felt muted. I've pronounced patients dead. I've watched families break apart in waiting rooms. I've delivered news that changes lives forever. But standing in that room watching a number that should have triggered immediate collapse, I felt something different. Not fear exactly, uncertainty. And in medicine, uncertainty is more unsettling than panic. Because panic has protocols. Uncertainty does not. Rachel's blood pressure ticked up again, 152/94. Keep it controlled, Ethan said. We don't need added stress. Tessa adjusted medication. The vibration didn't change. The number didn't fall. I leaned closer once more, placing my hand gently over her chest, feeling that steady hum beneath the layers of blanket and bone. The monitor climbed to 96, and Rachel kept breathing. I watched the waveform rise and fall, while her chest moved steadily under the ventilator. 96. Her blood pressure hovered in the low 150s. Heart rate steady in the 70s. Oxygenation perfect. Nothing about her systemic vitals suggested the kind of catastrophic neurological event that number implied. Let's reassess her exam, Ethan said. We just did, Tessa replied. Do it again. Sedation was adjusted carefully. Not stopped entirely, just reduced enough to evaluate neurological response without destabilizing her airway or triggering agitation. I stood near the head of the bed, close enough to see her pupils clearly. Rachel, Ethan said firmly,